and specifically to my good friend Professor Mohamed Morsi, for inviting me here. After 2 years online, I think we needed to be back all together. So my topic today is new technologies in shoulder arthroplasty, and first of all, we have to ask us the question: why do we need new technology? I think the challenges that we are facing today in arthroplasty is because we're all getting better in our surgeries. We have better implants available, and then we start to treat really difficult patients. First of all, very young patients with difficult deformities, but also older patients that changed their demands. They used to be treated conservatively because they were too old, but today they demand more treatment. And they often have, of course, bad deformities and bad bone stock. If you look at shoulder arthritis in a very simplistic way, the way the bone deforms is, of course, in primary osteoarthritis with posterior wear and posterior subluxation, while in cuff tear arthropathy, the humeral head migrates superiorly and makes wear on the superior, posterior-superior side of that glenoid. In reality, of course, it's much more complex than that, and we have understood more and more in the last couple of years that it's really more of a 3D glenoid deformity that we have to take care of. When today we are planning our arthroplasties, the way we look at it is we try to correct deformities by assessing the glenoid on standard X-rays or on CT scans, trying to assess glenoids in terms of version, in terms of wear and defects, and then try to figure out whether that glenoid fold can accommodate the implant that we had in mind, and then try to get it right for that patient in terms of the right position for version and inclination. The problem is, however, is that most of us use cannulated systems, and that means that the placement and orientation of that very first central pin will further dictate the whole preparation of the glenoids and the implant position. And if we do that using standard instrumentation, we have learned already a couple of years ago in this landmark paper from the Ainotti group in the Cleveland Clinic that we're not so precise as we thought we were. And the more deformity there is, the less precise we get. And this is up to 10 degrees of difference in between what we think we're doing compared to what we actually did. So that's not very good. So in a journey to get better at this, we also had experience even before this, when in 2007, and this is new technology but also vintage, because like I said, it's 2007, where we used computer-assisted navigation to improve our techniques for glenoid implantation for reverse arthroplasty. The only thing was that, and I think the hip and the knee surgeons experienced the same thing, that it was a very labor-intensive technology, did not really work smoothly, and in the end we abandoned it. But we learned a lot from it, just because of it's a new thinking. What we also learned is that just using 3D planning without specific instrumentation, just 3D planning and templating, makes you a better surgeon than when you just use 2D imaging and no templating. You will get rid of the outliers and you will get a better result in the end. And this was the start for many companies to come up with software to help surgeons to look at their patients in a different way. 3D software where you can look at the native glenoids, the native deformity, and also have the opportunity to use that software to see how you could correct certain glenoid deformities, what type of position you would prefer and think that would be best for that patient, and also decide what type of implant you would choose. Would you go for an anatomic replacement like in this one, where you can see that you have to sacrifice a lot of bone in terms of correction of the glenoids, or would it be better, for example, to switch to a reverse implant and see if that takes away less bone and may be better for the patient. And this is all virtual. This is all what you do preoperatively, and sort of a virtual preparation of your surgery. The question is then, how do you execute that plan? Can you execute that plan by using specific instrumentation, or do you use just standard instrumentation? We have published a long time ago the use of PSI as being very accurate in terms of execution of your preoperative plan. This has been shown in this study, and I can show you the very first shoulder that we did in 2014. And as you can see, it's not a difficult shoulder. This is more an easy type of glenoid, but I just wanted to show you how precise it is if you compare yellow being preoperative planning and red postoperative position. And this was the first PSI patient that was done by me and my good friend by then, Philippe Hardy. Since then, we have been using it mostly for difficult shoulders. We are in doubt of whether we should do an anatomic or a reverse arthroplasty. I'm still a big fan of anatomic arthroplasty. I think there's still an important role for that. And if I can save my patients with an intact cuff from a reverse, I will use all the technology that I have to correct the glenoids in the right way. And this is a quite recent publication where we showed that we were accurately correcting certain types of glenoid versions to postoperative acceptable versions. The mean preoperative versions was minus 15 degrees, where we corrected to about 6 degrees of retroversion, which is not zero, which is makes more sense in this type of patients. And as you can see, exactly using PSI guides to execute the preoperative plan for implantation of the central pin, and also reaming makes it more accurate. As I said, the technology is mostly now used for difficult glenoids, not so much for easy ones anymore. Difficult ones, like you see here, where it's not only difficult to find the central axis, but also you have to come up with some reconstruction of the glenoid fold as well, whether you use bone graft or metal implants. And here again, we use the same type of technology, PSI, in combination with grafts, in order to reconstruct these difficult glenoids. This is another example of a patient with an important glenoid deformity, a B3 deformity, that we reconstructed with PSI and bone graft here. As you can see, this was in the middle of COVID. He did not have any time or possibility to go to physiotherapy, and here he is, about 4 months after surgery, with a very good result. So a very difficult shoulder that was managed with new technology in a very efficient way. In some cases, bone grafts are not enough, especially if we're talking about older patients, 82-year-olds, E3 glenoid with a lot of superior inclination. And here we may, instead of using bone graft, we may use augmented implants. But again, based on the same technology, using preoperative planning, trying to figure out what is the best position for the patient. In this patient, as you can see, if we pull back the glenoid components and we use an augmented base plate, we can save some extra bone, and then this will make the implantation correct and not so difficult for you as a surgeon in a difficult glenoid. This is the final implant with an augment that we're using in this one. So I think this is only the tip of the iceberg that we're looking at. I think in the next decade or so, we will make so much more progression than we did in the last century in terms of newer designs, new technology, and the way we look at shoulders, not only in implants, but also in data collection. With all this new technology, we are able to collect all data, and we will be able, I hope, in the future.
In this type of patients, I'll decide.
I was too fast, sorry about that. Yeah, so I think in the next, we will be able to collect all these data and connect them to each other, looking at our data preoperatively, matching them to what we find intraoperatively, and then match them to postoperative results. And I think this will be a very interesting period that comes to us in terms of reality matching. Another technology that has come into our world is augmented or mixed reality. We have been using this since 2019. As you can see here, this one was one of the first ones that we used, where we overlapped 3D images on our patient and trying to use it as a sort of a guiding technology to get the implantation better. Of course, this is much simpler. This does not need any extra software or difficult technology during the surgery. But again, it's not really connected to the anatomy of the patient yet, so it's only just a sort of an advanced imaging tool where we try to use it to get a better implantation of the glenoid component. I think in the future we'll have more of these smart glasses to help us and better define the right position. Today we are still on only using it as a teaching tool.
I'll decide later on how long the central pec should be. I planned for 25, and I think this will be probably the best way to deal with it.
So using it as a teaching tool.
And then I can also show to
where we have used it during live surgery, so the faculty and also the participants, but also young surgeons and physiotherapists are now able to look through the glasses or the eyes of the surgeon, and by doing that, the surgeon can do this as a sort of an online classroom in order to facilitate education better. And then next and last but not least, I think sooner or later, and probably more soon than later, we will have robotic assistance in our OR to improve our implantation of the shoulder prosthesis. So I think and I hope we can see each other soon in another great on-site event, the CESEC conference, which will be held in Dublin later this year in September, and also maybe in the future I can invite